And ready to go?
Yep, ready to go, thank you.
Okay, right. Right, next we're going to talk about graft versus host disease, which is an important complication of stem cell transplantation. And depending on where you read and what you read, it's a complication that occurs in up to 60% of allogeneic stem cell transplants. So that's regardless of whether it's sibling or unrelated or matched or mismatched. That's the figure for allogeneic transplant that most people would accept. Some would say 30 to 60%. And I think sometimes we see a lot of it and then months go by where we don't see much of it. So it's always difficult to gauge how much of it there is out there. It's a really curious and interesting condition, and I think we've learned a lot about the immune system from GVHD. So obviously it stands for graft versus host disease, and it's a frequent complication that we see when the graft and the host are not genotypically identical. So unless you've had a transplant from your identical twin, you're at risk of having graft versus host disease, because although we may have matched you at the 10 important HLA loci and said you're a fully matched donor, or you're having a fully matched transplant, you're never going to be fully matched unless you've been transplanted from your identical twin. Those 10 loci that have been selected are proven to be of importance in grafting, in accepting the graft and in rejecting the graft, but they don't tell the full story. They give us a kind of workable framework to use for selecting donors. If we were to widen the criteria for donor selection, we would do far fewer transplants. So there's always a tension between matching, the degree of HLA matching we use, and the realistic possibility of having a matched donor. So there's compromises along the way, and we recognise that even on paper, if somebody is very well matched, their possibility is that they're crucially unmatched in areas that we don't look at or in things that we don't understand. And graft versus host disease is really what I want you to take away from this. It's the interaction between the tissue damage we do with the conditioning. Remember I told you that we condition with myeloablative alkylating agents, radiotherapy, chemotherapy, serotherapy. We make our patients very sick. It's very unusual to get through transplant conditioning without significant mucositis, the sort that requires a morphine infusion, causes a lot of vomiting and diarrhea, gives you febrile neutropenia, neutropenic enterocolitis. So we render patients very unwell before we rescue them with donor cells. So you can imagine that somebody who's about to receive a transplant has often got a pretty fired up gut, and probably other tissues as well that we just are not so aware about. And into that mixture, we're putting a healthy donor immune system. So we've got fired up donor tissues, we've got donor antigen presenting cells, and we've got immune competent cells from the donor. So this is, I think, quite a nice diagram that summarises that. And if you look at the top of the diagram, we talk about preconditioning of host with chemotherapy and radiation. So you'll all be familiar with what a patient who's received standard type chemotherapy can look and feel like after that. So that's our transplant patient. So they've got tissue injury and host cell activation. So remember, this is the patient we're talking about. We've caused mucositis in the gut. So there will be damaged gut cells that will be, and remember, damaged cells will be pounced upon by antigen presenting cells, and those could be tissue in origin, or they could be circulating they could be circulating macrophages that are around even after conditioning. And those that interaction between the damaged host cell and the antigen presenting cell will cause a cytokine and chemokine cascade that will lead to the release of tumor necrosis factor alpha and IL-1. just for kick-off. And with those chemokines and cytokines and your host antigen presenting cells presenting a bit of damaged gut, for example, that will attract the attention of our infused donor T cells. And those helpful CD4 positive cells will then become activated. And you know that when they become activated, they can themselves produce further chemokines and cytokines in the form of interferon gamma and IL-2, and that will cause our infused donor CD8 cells to become cytotoxic T lymphocytes. And those cytotoxic T lymphocytes will express MHC with antigen on the surface, and they will target host tissues. So those cytokine cells, those cytotoxic T lymphocytes have been primed up by the presentation of damaged epithelium, for example, to go and target epithelium, to get in circulation and target epithelium in the gut, for example. So you'll get ongoing gut damage that's been propagated by the stimulation of infused donor T cells. So in summary, we've got a damaged epithelial surface, say for example the gut, that is pounced upon by antigen presenting cells, which stirs up our infused donor lymphocytes to recognise to recognise the host cells as they would recognise non-self. And they are then primed to go and recognise inflamed gut, inflamed liver, whatever, as a target for their activity. So our healthy donor T cells are now recognising damaged host cells as a target. So if you remember anything, just remember that we've stirred up the donor, put in a healthy immune system. That healthy immune system recognises damaged tissue as non-self and goes on a full frontal attack. And this table is just to summarise. It talks about it in terms of 3 phases, and I think it's helpful to think of it in terms of three phases, because that helps us think about how we can reduce the incidence of GVHD. So phase 1, remember, is the effect of the conditioning. And the effect of the conditioning is to cause mucositis or hepatitis or any sort of inflammatory epithelial damage. And the host's antigen presenting cells then take a bit of that damaged tissue, present it, and cause the production of cytokines and chemokines, adhesion molecules, and lymphopolysaccharide. The next step is that the healthy donor T cells get activated. So it's mainly CD4 helper cells that interact with host antigen presenting cells, and they cause the next stage of the process with IL-2 and interferon gamma production. The third phase is the cellular and inflammatory effector phase. So that's when your healthy donor T cells, with the help of those CD4s, see the production of cytotoxic T lymphocytes, that's usually CD8 positive cells, and natural killer cells, and they go in for the kill. And when they do so, they produce a further cytokine storm. So it's not hard to understand why when you've got active GVHD, you've often got a fever and you feel pretty awful. There's a kind of ramping up of the inflammatory process. And the 3 phases are the conditioning phase, the T cell activation phase, and the cellular inflammatory effector phase. And if we think about, how might we reduce GVHD? One of the ways we try and reduce it for patients with benign disease is we try and give conditioning that's less likely to cause epithelial cell damage. So we've moved away from busulfan to treosulfan. We've moved away from radiotherapy to chemotherapy conditioning because we don't want GVHD. We've got other ways of trying to neuter the donor T-cell response, and that's by giving serotherapy before transplant. So that will knock out some of those, the population of T-cells that enter the activation phase and the cellular inflammatory effector phase. So just for the purposes of definition, sorry, I've skipped, we talk about acute and chronic GVHD, and acute is said to occur less than 100 days after transplant, and it predominantly affects the skin, the liver and the gut. That's a bit of a facile definition. It's much more useful to think of the acute GVHD as being what I've described above, that T-cell activation and inflammatory tissue response. Chronic GVHD was said to occur 100 days post-transplant, and that's how we used to classify it. But in fact, chronic GVHD is much more about humoral immunity and the involvement of B cells in the whole process. And it is much more like autoimmune systemic collagen vascular disorders. And it's multi-system and it's horrible. They're really they're different, but the difference is not the days post-transplant. There's no doubt that if you have bad acute GVHD, you are more likely to get chronic GVHD. But I have seen patients who've had minimal or no acute GVHD that I can remember presenting with bad chronic GVHD. And I've seen patients with bad acute GVHD who seem to have got away with it and not developed chronic GVHD. So signs and symptoms. Acute GVHD in the skin usually gives you a maculopapular rash involving the palms and soles. It can be actually painful. Having said that, it can occur anywhere in the skin, and sometimes it can start in the scalp and work its way down. Other times it can be mainly truncal and spare the limbs. And if it's minimal, you can treat it with topical steroids. If it's extensive and forming bullae, it can become desquamative and be life-threatening. So stage 4 GVHD has a very high case fatality. This is an example of an acute GVHD rash, and you can see that involving the soles of the feet, and it's sort of symmetric over the legs. That's nasty, as you can see, and I think the soles and the palms is an important place to look because it's rare to get rashes there. In the context of a post-transplant patient, that's an important discriminator. This is a skin biopsy showing you what's going on in the skin of somebody that's got acute GVHD. And one of the striking things it will show you is the lifting off of the epithelium from the underlying dermal skin. And that would probably show itself up as a kind of vesicle or bullous abnormality. You can also see that there's loss of layers of stratified squamous epithelium. That should be nice organised layers. Instead, we've got a bit of piling up of the keratinous layer, and we've also lost the nice normal pattern of maturation of the squamous epithelium. And at the base of the epithelium, this is a bit more disorganised looking. I'm trying to see if I can show you nice apoptotic figures, but I don't think this magnification allows that. There is definitely, though, probably inflammatory cell infiltration down here, and these are skin adnexal features. So you know, we might be talking about glands of some sort, and you can see that they don't look very normal. So basically, this is a feature of GVHD of the skin. Loss of normal architecture, inflammatory infiltration, bullae, that's the separation of the dermis from the epidermis, epithelial thinning, and hyperkeratosis. GVHD of the liver will show itself as cholestatic hepatitis plus or minus jaundice. Raised alkaline phosphatase is said to be a helpful discriminator, as is a raised gamma GT, whilst transaminases show non-specific changes. When you have GVHD of the liver in the acute setting, you're often having to disentangle it from infection, drugs, and veno-occlusive disease of the liver. It's rarely a diagnosis that's made on biopsy because your patient's usually pretty sick with very low platelets. So it's something we assume to be happening in the absence of identified viral infection with none of the normal associated features of VOD and when we've excluded significant drug interactions. So actually it's quite difficult to make a diagnosis of GVHD of the liver unless you're well platelet engrafted and you've got a brave gastroenterologist. It's often a derived diagnosis. GVHD of the gut is in theory easier to diagnose because we can have access to the gut with endoscopic biopsy. And the cardinal symptoms of it are nausea, vomiting, anorexia, abdominal pain, watery green diarrhea with potentially massive enteral fluid losses. You can imagine that the differential diagnosis of this post-transplant is going to be neutropenic enterocolitis, viral infection, drug effect. And this is to show you what happens microscopically to the gut. So here's a colonic biopsy specimen that's lost its nice organised villus architecture that you would expect in a colon sample. And instead we've got wee islands of crypts with lots of inflammatory cells surrounding them and loss of the nice normal absorptive surface of the colon. This is showing you the cells at the base of a crypt, and these little purpley areas are apoptotic figures. So that's, you've got increased rate of cell loss here, loss of normal architecture. So this is a colonic biopsy showing you acute GVHD grade 3, and I think that's probably going on the kind of gross appearance of the loss of nice architecture and the inflammatory infiltrate with crypt destruction and apoptotic cells. But there isn't an actual biomarker that you can use in a biopsy, it's an impression. And so for that reason, it's a frustrating diagnosis to wait for, because you'll always be told to accept the biopsy findings in the clinical context. So, and it's never usually possible to extract all the other factors and come up with a clean diagnosis. So we have to be able to grade GVHD, and it's easy in the skin. You just look at the percentage of the body surface area that's covered with a rash, and depending on the extent, you grade it a stage plus, 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 plus. You then combine it with the liver function. So if you've got significant GVHD of the skin and a high bilirubin, you've got you might have biopsy proven GVHD in the skin. The high bilirubin, it's likely to be the same process. So you can, if you get grade 2 plus in the skin and a bilirubin of 34 to 50 and diarrhea of less than 500, you can look at my next table and decide where you sit. That gives you grades. If you get 2 to 3, gut and or liver 2 to 3, you've got GVHD of grade 3. If we go back one, GVHD of the gut is quantified in terms of diarrheal losses. So if you're putting out more than a litre of stool a day, you're into grade stage plus plus plus. So you combine GVHD and its stage to come up with the grade. And GVHD of grade 4 has got an extremely high mortality risk. GVHD of grade 3 makes you very sick. GVH1 to grade 1 and 2 should be eminently recoverable and treatable. So the first thing we try and do is try and prevent this condition, because it's horrible to treat. That involves more immunosuppression, which makes you more vulnerable to viral infections, and it causes very distressing symptoms. So to prevent it, we try to give graft versus host disease prophylaxis in the form of drugs, and the commonly used ones are cyclosporin. So nearly every patient we transplant will be started on cyclosporin before we infuse the stem cells. And cyclosporin is that class of drug called calcineurin inhibitors, as is tacrolimus. And what they do is they blockade T cell activation. So if you go back to what we said about stages of GVHD, you've got tissue damage, you get T cell activation, then you've got the inflammatory phase. So this is trying to stop that that T cell activation stage of GVHD. Other drugs we use, sorry for flicking about here. Other drugs we use are methotrexate. We can give that post infusion, and it basically deals with donor T lymphocytes. Methylprednisolone, it reduces your lymphocyte numbers and is a kind of blunderbuss anti-inflammatory. MMF increases lymphocyte apoptosis, so it reduces the period of time that lymphocytes are circulating and causing chaos. Sirolimus, which is an mTOR inhibitor, it blockades T and B cell activation. It also upregulates T regulatory cells, so it has a role in preventing T cell activation as well. ATG, it just gets rid of T cells in the donor and in the patient because it hangs about in the circulation after it's infused for a number of months. Alemtuzumab gets rid of B and T cells, so is a useful anti-GVHD manoeuvre. So that's GVHD prophylaxis. Those are things we do ahead of the transplant to try and prevent graft versus host disease happening. So we can do it either by giving it to the patient before the transplant or adding it to the patient after the transplant. So that's the difference between in vivo and in vitro depletion. In vitro GVHD prophylaxis might mean that we remove some of the T cells before infusion. So we can decide that if we're using peripheral blood stem cells to just give the fraction containing the CD34 cells and not give the lymphocytes. And if you do that, you will reduce the GVHD incidence for the patient, but you'll increase the relapse rate for malignant disease. And you'll also potentially interfere with engraftment because it's known that you need T cells for engraftment. So that's not a manoeuvre that's commonly used. Treatment of GVHD is to use methylprednisolone at a dose of 2 mg per kilogram per day for 7 to 14 days with a calcineurin inhibitor, and you taper slowly if there is a complete response. And the clinical remission rate is between 25 to 40% of patients with grade 2 to 4 acute GVHD. But the important thing is, if you're giving somebody 2 mg per kilogram of methylprednisolone, you need to taper it slowly. If you stop it too quickly, you risk an out-primed immune system coming back with an absolute bang when you get rid of that steroid too quickly. And you risk ultimately exposing them to higher doses of steroids for longer. So you need to be quite clear about that. Failure to respond is when your GVHD continues to progress after 3 days on 2 mg per kilogram of methylpred, or there's no change after 7 days, or there's an incomplete response after 14 days. And in those circumstances, you need to do something else. So these are second line treatment of steroid refractory GVHD. So some people would say put the steroid dose up, and that sometimes works. We often add in other immunosuppressive drugs from different class. There's no point adding tacrolimus to cyclosporin because it's the same class of drug, but we might add in MMF or sirolimus. We might give locally absorbed steroids in the case of GI involvement. We might decide to use ATG, Campath, monoclonal antibodies like rituximab. We fairly commonly use extracorporeal photopheresis, and that's a non-immunosuppressive technique where you basically apherese the patient. You take out the aliquots of their blood and you separate it into a mononuclear layer of cells. So that's where the patient's T cells are going to be, and you subject them to ultraviolet radiation. You then return that aliquot of cells to the patient, and you're hoping that the patient's dendritic antigen-presenting cells may recognise them and take them out. So you're giving these effector T cells a sublethal dose of radiation, returning them to the patient, and then you are allowing the patient's own innate immune response to deal with it. So you're hoping that you get immune regulation as a result of this. It takes weeks or months to work, and it involves having an apheresis catheter with all the associated catheter thrombus risks that go with that. It's not an easy thing to deliver, but it's the least immunosuppressing of the manoeuvres we currently have. And it probably takes months to really show effect. We've also got mesenchymal stem cells, which were in favour a number of years ago, but seem to be dropping in and out of favour as a way of immune modulating the pathological T cell effect of the donor cells. Monoclonal antibodies I talked about. There is, I think, a thing to be aware of is when you see a menu of choices like this for a very awful disorder, that means that nothing really works that well, and people have been to the back of the cupboard and thrown everything they have at it. And I think we've used most of these to varying degrees of success. Basiliximab, daclizumab were very much in vogue a number of years ago, and they're anti-IL-2 receptor blockers. And you'll remember that IL-2 is involved in the T cell activation phase of GVHD. TNF-alpha, again, is involved in recruiting CD8 positive cytotoxic T lymphocytes. So it's not a bad thing to block it. And infliximab seems to have some specificity for gut GVHD. Alemtuzumab, it can be effective, but all of these MABs make you very immunocompromised, so they come at a cost. You risk increasing the risk of viral reactivation and other potentially life-threatening consequences. It's really important not just to give more immunosuppression, but to up your supportive care for patients with graft versus host disease, because they're very immunocompromised. So that might involve total gut rest for a while and parenteral hyperalimentation. Maybe that's GVHD, maybe it's being on very low volume nasogastric feeds until you build up into proper alimentation. IV fluids, pain control, infection prophylaxis. You mustn't forget to give these patients infection prophylaxis and regard them as extremely vulnerable. So that's acute GVHD. Now we're talking about chronic GVHD, and chronic GVHD is horrible, and it's like all those connective tissue diseases you see in adults. It's insidious, it's incrementally awful, and it's a life sentence. So it's important to try and prevent GVHD, because you could be replacing somebody's non-fatal disease with a really awful survivorship if they develop chronic GVHD. In the context of leukemia, there's good evidence that if you get chronic GVHD, your chance of relapsing from your leukemia are much reduced, but it does come at a price. Then the chances of it happening are increased with grade 3 or 4 acute GVHD. And the other factors that increase your risk of chronic GVHD is if your patient is older, if your donor is older, if you use female donors for male recipients, if you use donor lymphocyte infusions, if you use unrelated or HLA mismatched donors, and if you use peripheral blood stem cells as a stem cell source. And the pathophysiology of chronic GVHD, that should say up there, not just GVHD, it's basically this stage that makes this disease resemble a lot of the autoimmune diseases you'll be familiar with. So basically you get development of acute GVHD. That causes thymic injury. When you get thymic injury, what you lose out on is your T regulatory cells that are able to take out self-reacting T cells. So the reason we've not all got autoimmune disease is if our lymphocytes react to self-antigens, we've got T regulatory cells that say, come on, I'm not letting you cause inflammation here, you're out. So our thymus is geared up to recognise autoreactive T cells. But if you've had a transplant and you've had GVHD, your thymus is not doing that job. So you get release of these autoreactive T cells into the bloodstream, and they hype up your CD4 cells. So these CD4 helper cells help activate host B cells to produce autoreactive B cells and autoantibodies. And what you can end up with is conditions that resemble scleroderma, morphea, arthritis, Sjogren's, all those horrid chronic autoimmune diseases of adulthood. So you can have dry eyes, you can have lichen planus of the mouth, you can have nail dystrophy, you can have sclerosis of the skin. And sclerosis of the skin is horrible. So when you touch this man's skin, you don't get, it'll feel like a tree trunk. It'll be stiff. And you can see here that the dermis is expanded with very broad connective tissue. I don't know. No, I'm not muted. Hi, can you hear me next door? Hello?
Yeah, I can hear you.
All right, okay, sorry. I'm not muted. Sorry, there was a bit confusion there. I don't know if next door can't hear me. So yeah, chronic GVHD of the skin causes a kind of morphea-like change in the skin with tree trunk consistency to the skin, and it can cause stiffening of the joints. So part of the reason you get fixed flexion contractures is because of the soft tissue sclerosis in the subdermal region. So it's very disabling. You can get a deeper sclerosis that can affect soft tissues of the joints. You can get bronchiolitis obliterans in the lungs. So that's a condition that will interfere with oxygenation and eventually lead to cor pulmonale. You can get disappearing bile ducts in the liver, and that will cause a fatal hepatitis. You can get fasciitis of the joints, skin ulceration because of the loss of normal skin architecture and the normal adnexal structures of the skin. There's no skin nourishment going on, and it causes a really globally awful impact on quality of life. So your mobility is affected, your appearance is affected. You've got dry eyes, ulcerated mouth. It's a horrible condition, and one that's very sad to see in young people, especially. This is probably not a very old patient we're dealing with in this image. And this is just a kind of summary of the appearance of chronic GVHD. With the skin, you can also get depigmentation, which might be a clue to it's happening. Nail dystrophy, alopecia, lichen planus, mucositis in the mouth, Sicca syndrome in the eyes, lichen planus of the genitalia, and that can be especially troublesome in females. GI tract fissures, exocrine pancreatic insufficiency. You know, it's a horrendous toll. In the lungs, we can get bronchiolitis obliterans. In the hemopoietic immune system, thrombocytopenia is commonly seen, as is eosinophilia and lymphopenia. So these patients are very immune suppressed and may well have cytopenias. So the primary treatment of it is we usually start with steroids, and we introduce cyclosporin. And the initial steroid dose is lower than that for acute GVHD, and the duration is usually more prolonged. So you see lots more steroid-associated symptoms in patients with chronic GVHD because of the long exposure. So AVN, diabetes, infection, hypertension, cataracts, these are all risk factors. There is a promising new treatment I wanted to bring to your attention, and we've recently had good success with ruxolitinib, which, as you probably know, is a JAK inhibitor. It inhibits the JAK-STAT pathway, and in so doing, it inhibits signalling of cytokines and growth factors that use the JAK1 and 2 paths for signalling. So it was a drug that was used originally in myelofibrosis and has been adopted in GVHD. And in this paper referred to below, it's reporting at least 80% partial responses in acute and chronic GVHD in children. So this is a very exciting development because it's an orally active drug, and it can cause cytopenias and it can cause deranged LFTs, but we're seeing it as a well-tolerated drug. And if it can start to reverse some of the awful changes of chronic GVHD, it's a very welcome adjunct. I just wanted you to be aware of that's one of these drugs that's shown some promise in this otherwise very depressing situation. Other drugs that have been used in GVHD recently, and again they've come from other places, is brentuximab. So if folk fail ruxolitinib, others are offering brentuximab as a promising agent. It's not something we've used in paediatrics as yet, though. And this is just to show you, this is actually a slide in German, and I'm sure your German is all up to understanding what's going on here, but it shows how ruxolitinib works. So I thought it was quite nice to just broadcast to you. I don't speak German, but I think this means chemotherapy and or radiotherapy. And this is damaging epithelial cells. Here are your antigen presenting cells. Here are your naive donor CD8 and CD4 positive cells. Then your cytokines interact here. Here are your regulatory T cells. And in comes, and this is your organ damage, so it damages your skin, your liver, and your gut. So ruxolitinib comes in and interrupts this pathway. Let's see. Oh, sorry, I thought I had something at the bottom of this slide. But Rux, I think, allows your regulatory T cells to get in there and prevent the destruction by cytotoxic T lymphocytes. So for chronic GVHD, there's no standard second-line therapy. It's one of those areas where there's a lack of, for many years there's been a lack of progress in treating it. There's various therapies that have been adopted, including low-dose lymphoid radiation, PUVA therapy, ECP, MMF, tacrolimus, thalidomide. We've had some encouraging responses with rituximab, but I think that's not our go-to drug anymore. We're much more enthused by the prospect of ruxolitinib. And we've got to always bear in mind the need for antimicrobial prophylaxis and supportive care, as we would offer in acute GVHD for those who are burdened with chronic GVHD. So So basically, that's the end of my presentation, and I'm sorry I've lost the time. I think we've probably gone over, have we? Hello? Anybody out there?
Hi, Anna Maria.
Hi.
It's fine, no worries.
Hi. Is there any questions? Hi there. Any questions? Okay.
Silence.
If there's no questions, I wondered if I could trouble you to give some feedback. It's very easy. If you've got a mobile phone and you go to socrative.com, select the student login. I mean, it really is very easy. You can be anonymous. The room name is Ewins 400. And it'll ask you 4 very easy questions. And please be honest, because